Good day, dear colleagues. Today we will talk about the mesenchymal or soft tissue tumors, also about the tumors of the nervous system and dysontogenic tumors with the peculiarities of the tumors of the childhood. So, mesenchymal tumors, it's a great group of the tumors. It's not very frequent tumors. It's rare tumors, but it's a wide group. Which include a lot of different tumors growing from the mesenchymal tissues, means tumors which forms from the mesenchyma. As you know, that is a fibrous tissue, adipose tissue, skeletal muscles, smooth muscles, blood vessels, bones and cartilage, and mesothelium. So very big group. We will talk about benign and malignant tumors. When we give the name for the for benign tumor of the mesenchymal region, we added suffix "oma" to the name of tissue. Means adipose cell tumors, which can be benign. That will be lipoma. And if we want to give the name for the malignant tumor, we added word sarcoma. It's turned to lipoma, turned to liposarcoma. So malignant variant of the adipose tissue tumor will be liposarcoma. Fibrous tissue tumor, fibroma and fibrosarcoma, myoma and myosarcoma, etc. A lot of. All mesenchymal tissue tumors classified not only to the benign and malignant but also to the benign tumor with a local invasion. It's something intermediate form, and this tumor has infiltrative type of the growth, but it's benign. It has no features of the cell tibia. Now we'll talk about the tumor of the fibrous tissue. Benign, just several examples: fibroma, desmoid tumor, and dermatofibroma. Malignant variant, we choosing fibrosarcoma and malignant dermatofibroma. Fibroma, that is a organ-non-specific tumor which forms in different organs and tissue. More often it's a breast, skin, ovary, uterus, and tendon sheets. It's benign. It's composed of the fibrous tissue, mature connective tissue. We are divided all fibromas into the soft and hard. Soft, it's histologically consists predominantly from the cells with a small amount of the collagen fibers, and the hard fibroma contrast. It consists more from the fibers than the cells. Macroscopically, all fibromas look like a whitish color, round oval shape nodule with a dense consistency. It's well circumscribed. We have no any features of the cell atypia. Desmoid tumor or deep fibromatosis. It's a benign tumor with a local invasions. There are two main forms, nodular and diffuse. We also can classify desmoid tumor into the abdominal fibromatosis, extra-abdominal fibromatosis, and intra-abdominal fibromatosis. Abdominal fibromatosis, it's a tumor of the front abdominal wall, which more often grows in pregnant ladies. Extra-abdominal fibromatosis, it's affected shoulders and the thoracic muscles without any male-female predominance. Intra-abdominal fibromatosis, it's localized in the mesenteric, pelvic, retroperitoneal areas. It's associated very often with the Gardner syndrome, which include adenomatous polyposis. We talk about these conditions on the previous lectures. skin tumors, and osteomas of the skull. Dermatofibroma, or benign histiocytoma. It's a small fibrous node with yellow-brown color. It's located on the skin of the legs, more often near the elevated bony areas. I mean near the joints very often. Histologically, it's composed of the intertwined and anastomosizing bundles of the fibroblasts surrounded by the dense collagen. There are giant polynuclear cells with the lipids and hemicide ring present between the cells. Now about the malignant tumor, fibrosarcoma. Fibrosarcoma more often localized in the deep soft tissues. It's showing increased fibroblastic cells, very severe anaplasia, pleomorphism of cells, abundant mitotic features. These tumors may look like a node, can be encapsulated or with a diffuse type of the growth. There are 3 types of fibrosarcoma according to the histological appearance, and based on this histological appearance, it's lead to different clinical features and different answer for the treatment. So we have a differentiated fibrosarcoma, poorly differentiated fibrosarcoma, and brown cell tumor. Differentiated fibrosarcoma is characterized by the prevalence of the fibrous component over the cellular components. It means that the tumor cells, fibroblasts, tumor fibroblasts, atypical fibroblasts, can produce the collagen fibers, so it has some speciality. In case of the poorly differentiated fibrosarcoma, we also name it cellular sarcoma. We can see a lot of cells, but just a single collagen fibers. This tumor produces metastasis very frequently and very fast because of the weak intercellular contact. Also, we have a round cell tumor of unknown origin termed unclassified tumor, but if we make the correctly immunohistochemical investigation, we may find some antigen of the fibrous tissue. Dermatofibrosarcoma protuberans, or malignant histiocytoma. It's well-differentiated, slow-growing fibrosarcoma of the skin. Locally aggressive, but rarely metastasized. Grossly, it looks like a multilobulated, great, whitish, flashy nodule, which can have infiltrative growth, and this tumor is non-encapsulated, but may be well circumscribed. Microscopically, cellular neoplasm composed of the radially orientated, like storiform fibroblasts showing spinels and polygonal cells. Mitosis are not as numerous as in a fibrosarcoma. The overlying epidermis is thin, and there often is microscopic extension into the subcutaneous fat. It's very important diagnostic criteria for high, well-differentiated dermatofibrosarcomas. Adipose tissue tumors, it's classified also into the benign and malignant. The main of it's a lipoma and hibernoma, liposarcoma, and the malignant hibernoma. Lipoma, it's arising from the subcutaneous fat, so it's mostly localized in the back, shoulder, and neck. Sometimes it's also arises in the mediastinum, retroperitoneum, or in the bowel wall. Lipomas are encapsulated usually small yellow color nodules which has a lobulated structure in the cross section. Intramuscular infiltrating lipoma is a tumor without distinctive or clear borders. It infiltrates to the intramuscular connective tissue, but it's not a malignant. It's a benign tumor because we have no any features of the cellular atypia and mitosis. Hibernoma. It's tumor from the brown fat. As you know, it's embryonic tissue which normally present in the buttocks and at the cheeks of a newborn. The fat cells or adipocytes of the brown fat consist granules, pinkish color granules, and if the tumor grows from these granular cells, we talk about the hibernoma. It's rare tumors, just 2% of the all lipomas. Mean age, it's 26-38 years old with a male predominance. Typical location, it's axillary, back, mediastinum, shoulder or thigh. Sometimes this tumor may produce steroid hormones. Microscopically, we can see organoid arrangement of uniform large cells resembling brown fat with a coarsely granular or multivacuolated cytoplasm that is eosinophilic or pale. Vacuoles are small and stained for natural fat. Nucleus is small, central, with no or rare features of atypia. Often, mixture of white fat. May have loose basophilic matrix, features of spindle cell lipoma, only scar the hibernoma cells, but it's rare. Subtypes: classic, lipoma-like, myxoid, and spindle cell. Malignant variants of the hibernoma, it's very rare. In this case, we can see features of the cellular polymorphism, presence of a lot of giant cells, and atypical mitosis. Liposarcoma. It's a rare large tumor which is composing of the lipocytes and different degrees of maturation of the lipoblast. There are several types of liposarcoma: well-differentiated, myxoid, round cell. Well-differentiated or lipoma-like liposarcoma look like benign tumor like lipoma, and it's very difficult to make that correct diagnosis, to make differentiation between the well-differentiated sarcoma and lipoma. Myxoid or embryonic liposarcoma tend to be low-grade tumor which are stubbornly recurrent, follow a more protracted course, and metastasize late. Pleomorphic liposarcoma, it's a rare, high-grade aggressive sarcoma. It gives a metastasis in 85-90% of cases. Tumors of the muscular tissue. We will talk about the leiomyoma and the rhabdomyoma in the benign, and leiomyosarcoma and rhabdomyosarcoma like malignant variant of this tumor. Leiomyoma. It consists of the smooth muscles cells with a aortic location of the muscular tissue bands and stroma with the vessels and nerves. If the stroma in the tumor prevails, we name it fibromyoma. Fibroleiomyoma. Leiomyomas occur predominantly in the female genital tract, but they may also occur in the other body sites, whether the normally present the smooth muscle, like in the skin, in the scrotum, nipple, bowel wall, stomach. But more often, of course, it's uterus. Everybody knows about the uterine leiomyoma. These leiomyomas may be single or multiple. It's may localized submucosally, subserosely, or intramurally. It may have an indolent duration, or it may lead to severe complication like an infertility, like bleeding, etc. Secondary changes. Very often in the leiomyoma we can see secondary changes. It's necrosis, hemorrhages, cyst formation, hyalinosis, petrification, and myxomatosis. That's because this tumor is estrogen or hormone connected tumor, and this tumor grows faster in conditions when the woman has excessive level of the estrogen. Rhabdomyoma. Rhabdomyoma consists of the striated muscles. It resembles embryonic muscular fibers and myoblasts. It appears against the background of the tissue shifts and is accompanied by the other development defects like large masses of the striated muscles. The tumors are most frequently primary tumors of the heart in infants and children, and are frequently discovered in the first years of life because it leads to obstruction of the valve orifice or cardiac chambers. Malignant variants of the muscular tumors. It's a leiomyosarcoma and rhabdomyosarcoma. Leiomyosarcoma or malignant leiomyoma, it's a tumor with cellular and tissue adipism with a large number of mitoses, high mitotic index. These are red tumors surrounding in the skin, deep soft tissue, stomach, and particularly in the uterus from the pre-existing leiomyomas. Rhabdomyosarcoma or malignant rhabdomyoma. More often it's formed in the children in the head and neck and urogenital region. It is subdivided into the four type based on the morphological features. Pleomorphic type occur in the patient over 45 years old. This variant has large atypical tumor cells, some of the cells showing abundant cytoplasm with a cross striation characteristic for skeletal muscle cells. Embryonal botryoid alveolar types are poorly differentiated tumors of the small blue cell that have a focal skeletal muscle differentiation, rhabdomyoblast with abundant eosinophilic cytoplasm or cross striation. Botryoid pattern is basically a morphological variant of the embryonal with the grape-like masses projecting into the cavities such as vagina, bladder. This tumor may be apparent only with a immunohistochemical investigation. Tumors of the blood vessels. We will talk about the benign and the malignant also. Benign hemangiomas and one more variant, not really blood vessels tumor, but it's connected with it. It's a glomus angioma or glomus tumor. Malignant. Malignant can be malignant hemangioendothelioma, malignant hemangiopericytoma, and a Kaposi sarcoma. Hemangiomas. It's a benign vascular proliferation, sometimes related with a syndrome, congenital syndrome. We are classified into the cavernous and the capillary. It looks like a well-circumscribed reddish color nodules which may present on the skin, on the mucous membranes, maybe in the internal organs, in the brain, spleen, liver, intestinal wall, everywhere. But it looks like a red color lesion. In the skin and mucous membrane, sometimes it may be slightly elevated above the surface, but may be flat. Cavernous hemangioma, localized or diffuse. It consists of the blood-filled sinus-like spaces with scant connective tissue, variable smooth muscle. It may have infiltrative type of the growth, but it's not a malignant. Capillary hemangioma. It's smooth, closely packed capillaries, rarely multifocal. It's no features of the suggestive or malignancy. Other rare variants with a distinctive morphology can occur, such as anastomosiding hemangioma. All these tumors, if it's on the skin, can be treated surgically very simply, but Unfortunately, when this tumor present in the internal organs, it may be diagnosed only incidentally or in a case or after the rupture of these tumors, like rupture of the hemangiomas in the brain or in the liver. It may lead to catastrophe in the organism. Glomus tumor. It's a mesenchymal tumor composed of the modified smooth muscle cells arising from the glomus body. It has predominantly cutaneous location, mostly localized on the subingual region of the finger, but may occur anywhere. It looks like macroscopic. It looks like a bulging mass with an irregular nodular hemorrhagic cut surface. It's painful. If we press this tumor, the patient feels pain. Usually it's benign with a very rare malignant variants. Microscopically, we can see combination of the glomus cells, smooth muscle cells, and blood vessels. Glomus cells, it's round punched-out nuclei with a amphiphilic to eosinophilic stroma surrounding branchy capillary-sized vessels. So it's what do we see? Kaposi sarcoma. Vascular neoplasm caused by the human herpes virus 8. It's tend to be indolent but may be locally aggressive. It's composed of the slit-like vascular spaces formed by the spinal endothelial cells with a minimal to moderate atypia. Also include a lot of the hemorrhages with the hemocyte deposits and plasma cells in the infiltrate. Location, predominantly skin, but also may affect internal organ, mucosa and lymph nodes. We have 4 main variants of the Kaposi sarcoma, clinical morphological variants. It's a classic, endemic, iatrogenic, and AIDS-associated. Classic, also named sporadic or European variant. It's affected mostly elderly men over the 60-70 years old. It's localized on the skin of the lower extremities. May associated with a secondary malignancy. Clinically, indolent cars with long duration without metastasis or in a very deep stages formation of metastasis. Endemic variant, also named African. It's also affected extremity skins, lower extremity skins, but age of the patients is children and young adults. It's not related with the human immune deficiency virus. This tumor is more aggressive. It grows into the lymph nodes and internal organs and metastasize very fast. Next variant, it's a iatrogenic or other name renal transplant. It's connected with the immune suppressive therapy which we use during the transplantation of the internal organs or skin. Predominantly associated with the transplantation. Affected skin, visceral and mucosa often. AIDS associated, it's a last variant. It's affected the patients with a human immune deficiency virus. Predilection for a certain risk groups, for example, risk for homosexual man is greater than the hemophilic patients. Affinity for the skin but may be disseminated for the skin. In contrast to the classic forms, in the AIDS-associated form of Kaposi sarcoma, we can see a main lesion on the face, tip of the nose, maybe neck, so open areas of the skin. It's the most aggressive variant of the Kaposi sarcoma. It grows faster and gives the metastasis very fast. In its clinical morphological duration, we have 3 stages on Kaposi sarcoma. It's a patch stage, plaque stage, and nodular stage. Patch stage we can see dilated vascular channels dissecting through dermal collagen. Promontory sign: tumor vascular channels surrounded and entrap native vessels. Classic but uncommon features. May be very subtle in early lesion. Plaque stage: more extensive, compressed, slide-like vascular channels infiltrating deep dermis. Infiltrative proliferation of spindle endothelial cells resemble to fibroblasts. Spindle cells infiltrating and destroying eccrine coils is very characteristic. Nodular stage, characterized by the presence of the discrete nodules composed of the intersecting fascicle of uniform spindle cells. Intervening blood-filled spaces between spindle cells, slit-like spaces, and sieve-like spaces on the cross-section. Intracytoplasmic hyaline globules may be seen also in this stage. Tumor of the mesothelium. It also can be benign and malignant. Benign occurs mainly in the peritoneum. These tumors is less than 2 cm are considered benign, while larger tumors are more likely disseminate. Thin fibrovascular papilla lined by relatively uniform cuboidal mesothelial cells, its main histological appearance. Also, we can see psammoma bodies. Malignant mesothelioma. It's aggressive neoplasm of mesothelial differentiation, epithelioid, biphasic, and sarcomatoid subtype we can classify. Overall survival for 27 months, depending on the subtype and the stage of the disease. Most commonly, it's associated with a remote asbestos exposure. Tumor of the bones. Main benign tumor of the bones. It's osteoma, osteoid osteoma, osteochondroma, osteoblastoma, and chondroma. Giant cell tumor, which we also name osteoblastoblastoma, and solitary cyst, and fibrous dysplasia of the bones like subvariants. Malignant bony tumors. It's osteosarcoma and chondrosarcoma. In this tumor we have infiltrative type of the growth, higher mitotic activity, and presence of metastasization. Now we go to the tumors of the nervous system. Tumors of the nervous system is 1.5% of cases among the all patients with the tumors. Not so big, but all tumors of the brain in the central nervous system, if this tumor is benign or malignant, it has a tendency to clinically be malignant because it grows in the close area. But also, I want to pay attention that 20% of tumors of the childhood, it's a tumor of the nervous system. Origin of the tumors of nervous tissue. It can be central, autonomic, peripheral, and mesenchymal. Tumors of the central nervous system are divided into the two main big groups. First is the neuroectodermal, which build from the derivatives of the neuroectoderma, and meningovascular. Neuroectodermal tumors. The main of it grow from the astrocytes, oligodendroglyocytes, ependymal cells, and hydroid epithelium, neuron, and some embryonic cells. Clinical symptoms divided into three groups. It's brain symptoms, foci symptoms, and dislocation symptoms. Brain symptoms include headache, vomiting, dizziness, congestion of the optic nerves, epileptic seizures, psychiatric disorders. Focal symptoms depend on location of the tumor. Dislocation symptoms, it's tentorial wedging, craniovertebral wedging, and lateral displacement. First of all, we will talk about the astrocytic tumors because it's more frequent. It's classified into the several groups according to the malignant potential. Astrocytoma, it's a benign tumor. It's subdivided into pilocytic or juvenile. It consists of the parallel bundles of the glial fibers, which in appearance resemble the hairs. That's why pilocytic. Usually it's well demarcated from the surrounding tissue. It grows slowly, but when it starts to compress the brain tissue, it's begin give the clinical symptoms. Other variants of the well-differentiated but low-grade astrocytoma, it's astrocytoma fibrillary variant. It's a most frequent variant, occurs mainly from the fibrous astrocytes, allowed a small amount of the fibrillar protoplasmic astrocytes. Next variant, malignant astrocytoma. It's an anaplastic astrocytoma. Peak of incidence in 38 years old, so it's like a young adult. Most commonly found in the cortex and the white matter of the cerebral hemisphere, can occur anywhere in the central nervous system. But as you see, it's more often frontal lobe with the typical frontal symptoms. Tumors consist of diffusely infiltrating cells, oval to elongated astrocytic nuclei, and varying appearance of tumor cytoplasm and fibrillar glial processes. Defined increased mitotic activity, cellularity, and nucleotopia compared to that of the diffuse astrocytoma, so we turn it to the grade 2 malignant potential. In a small biopsy specimen, the presence of the one mitosis may be sufficient for the diagnosis, while the presence of the few mitotic features in a large resection would not be sufficient for the anaplastic designation. Necrosis and microvascular proliferation will be absent. Main in the histological diagnosis, it's nuclear atypia of the astrocytes and polymorphism of astrocytes, sometimes with mitosis. Astroblastoma or malignant astrocytoma. Glioblastoma multiforme is a more aggressive tumor. It has very rapid type of the growth. Histologically, cell clusters consist of the spongioblast, astroblast, and astrocytes with chaotic arrangement of the tumor cells, polymorphism of their nuclei, anisonucleosis, foci of necrosis, vascular changes, and extensive perifocal edema. It's diffusely infiltrate, febrile, and vascularized tumor. Peripheral grayish rim of tissue with the central areas of the yellowish necrosis from the myelin breakdown. We can see also a lot of the thrombotic vessels, foci of the hemorrhages, like secondary changes. Oligodendroglioma, mostly benign and usually slow-growing intracerebral glial tumor derived from the oligodendrocytes or progenital cells, usually localized in the hemisphere of the brain. Despite the nodular shape, has an infiltrative growth. Anaplastic oligodendroglioma, also named atypical dedifferentiated oligodendroglioma or oligodendroglioblastoma. It's a malignant variant. The tumor is composed of the undifferentiated cells oligodendroblast. Ependymal tumors and tumor of the choroid plexus classified also into the benign and malignant, and if the tumor grows from the ependymocytes, we name it ependymoma benign and ependymоblastoma malignant. If it grows from the choroid plexus, benign variant we name choroid plexus papillomas, and the malignant variant choroid plexus carcinoma. Hyaloid plexus papilloma, benign neoplasm of the hyaloid plexus. Its structure made from the tuft of the villi within the ventricular system that produce cerebrospinal fluid. That one of the main symptoms in this tumor may be increased pressure of the in the liquid dynamic system and with the all accompanied symptoms. Hyaloid plexus carcinoma. It also consists of the tuft of villi, but with a layer of neoplastic hyaloid plexus epithelial cells with a pleomorphic nuclei, with increased nuclear cytoplasmic ratio, with increased mitotic activity, multiple necrosis, and typical brain invasion. Ependymoma. According to the structure, ependymoma is divided into the three types. It's a procellular, epithelial, and capillary ependymoma. This tumor grows slowly with a narrow zone of the infiltration. Main histological features of ependymoma: it's the presence of the true and false rosettes, perivascular false rosettes or pseudo-rosettes. It's when the tumor cells radially surrounding the blood vessels localized, and the ependymal true rosettes, it's when the cells localized around the central lumen with the cerebrospinal fluid, and it's no blood vessels inside. Ependymoblastoma. It's an aggressive central nervous system tumor, embryonal origin, with a multi-layered rosettes and amplification of some gene. Rare tumor of the children aged less than 4 years old. Other tumor in this group are embryonal tumor with abundant neuropil and true rosettes and medulla epithelioma. This tumor is well circumscribed, grayish-pink, with areas of necrosis and hemorrhages because of the secondary changes. Rosettes are a frequent characteristic of this tumor. Sheets and clusters of poorly differentiated cells we can see under histological investigation. We also must pay attention to the false and true rosettes formation, like a diagnostic criteria of the ependymal region of this tumor. Neuronal tumors: ganglioneuroma, neuroblastoma, and ganglioneuroblastoma. Ganglioneuroma, it resembles to neurofibroma, plus with a numerous cluster of the mature giant ganglion cells, often multinucleated. Neuroblastoma, it's small round blue cell tumor with the hammer-right rosettes and neuropil. Microcalcification and necrosis also can be seen. Ganglioneuroblastoma, rare tumor characterized by severe polymorphism. Meningeal tumor. Meningioma, also named arachnoendothelioma, is developed from the endothelium of the meninges. Meningiomas are 13–19% of all intracranial tumors and 40% of the tumor of the spinal cord. This benign tumor grows as a node of extracerebrally convexital or basal surface, occasionally in the ventricles of the brain or the spinal canal. According to the histological structure, may be different. Meningothelial with the concentric structures, subamatose, fibroblastic, angiomatose, xanthomatose, ossificated, and mesenchymal. Meningeal sarcoma. Its tumor has dural location, may be well circumscribed or radially adherent to the brain parenchyma. Size may be different. Grossly, we can see nodule with an infiltrative grooves. We have no features of necrosis in this tumor. Histological criteria for the diagnosis It's a presence of anaplasia and more than 20 mitotic features per 10 high-powered fields, or displaying frank malignant sarcomatose or carcinomatose histology. Most also show extensive necrosis sometimes. Proving meningothelial origin can be challenging, so immunohistochemistry can help us. Tumors of the autonomic nervous system include ganglioneuroma, hemodectoma, ganglioneuroblastoma, sympathoblastoma, malignant hemodectoma. Some of that's benign, some malignant. Hemodectoma. The most common symptoms include hearing loss, ringing in the ears, paralysis of the facial nerves, muscles, labile blood pressure because of the secreting of the catecholamines. Paraganglioma of the carotid bodies, a slow-growing benign brain tumor derived from the paraganglial cells of the expansion of internal jugular vein. Their frequency is 0.6% of all intracranial tumors. Women suffer it up to 6 times more than a man. Median age is 55 years old. Glomus tumor can be detected as the extracranial and intracranial tumor of peripheral nervous system. Benign neurolymphoma or schwannoma, neurofibroma and neurofibromatosis, and malignant variant named malignant schwannoma. Schwannoma is constructed of spindle-shaped cells with rod-shaped nuclei. Cells and fiber forms bundles forming riming or palisade structures, interleaving portion of parallel length nuclei, nuclear palisade or verrucai bodies, with the portion of composed of the fibers. Neurofibroma, tumor associated with the membrane of the nerves, consisting of the connective tissue with a mixture of the nerve cells, bodies, and fibers. Neurofibromatosis or Klein-Gausen disease, a systemic disease characterized by the development of the multiple neurofibromine, which are often combined with a variety of the development disabilities. There is a peripheral and central forms of neurofibromatosis. Our next part of our lectures is tumor of the melanin-producing tissue. Melanin-producing or melanin-forming tissue, it's a neurogenic origin cells, melanocytes, which can be source of the tumor or tumor-like formation, which we call NAVI, and the true tumors, but it's malignant tumor, malignant melanoma. Pigmented nevus, a benign tumor of the neuroectodermal region which locate in the skin. Melanoma, high malignant melanocytic tumor of neuroectodermal region. It's the main position in this part of the lecture. Pattern, which is associated with a benign behavior. It's a small size, circumscription and symmetry, nested proliferation with the nest regularly distributed at tips of the red ridges. Melanocytes nucleus smaller than the adjacent keratinocytes. Uniform cellular density throughout some level of lesion. Melanocyte decrease in size toward base of the lesion, names maturation. Coalescent eosinophilic globules like camina bodies are associated with the Spitz nevus. Absence of mitotic activity. Also, rare mitosis may be seen in the benign nevi. Lack of necrosis and cytologic atypia. It's all pattern of the benign. Classification of the nevi. Very big classification. Great classification include borderline intradermal compound epithelioid or spindle-like blue or nevus aorta, broca, eta, a lot of. We will talk just about several of it. Borderline nevus, clinically characterized by the solitary spot, rarely popular dark brown or dark gray or black, with a diameter usually not more than 1-2 millimeter. The surface of this lesion is smooth. Favorite location: palm, soles, genitals. There is a congenital or develops at a young age. Nevus cells are located in the boundary of the epidermis and dermis. Intradermal nevus, composed of the nest and cord of nevus cells, which are located only in the dermis. Nevus cells contain a lot of melanin, often found multinucleated giant cells, which we call Teuton cells. These lesions sometimes look like papilloma. That's why we name it papillomatous intradermal pigmented nevus. Compound nevus has the signs of the borderline and intradermal nevus, both of them. Epithelioid or spindle cell nevus occur mainly in the face of the children, composed of spindle cells and epithelioid cells with a clear cytoplasm. It contains multinucleated giant cells. Cells contain small amount of the melanin, or it's totally absent. Blue nevus. Blue nevi are common in people 30-40 years old, mostly in derma of the buttocks and extremities. It has the form of nodules with a bluish tint composed of the proliferation of melanocytes that can grow into the subcutaneous tissue. Factors which contributed to the malignancy of the intradermal nevus, that is, increased insolation, trauma, endocrine disorders, and genetic factors. So it's very dangerous to make a trauma of the nevus because it can malignize. It's very dangerous to have a lot of insolation present, a lot of time in the sunlight exposure, because it may lead to the malignization of the nevus. And of course, if you have the pale skin and a lot of nevus, it's dangerous because it may transform to malignant tumor, to malignant melanoma. On the scheme, you can see the main signs of the benign and malignant melanoma. Benign nevus mean in malignant melanoma. A, B, C, D, E system can help us to differentiate benign and malignant lesion. A, it's asymmetry. If the tumor has a symmetrical part, if we cut it into the two pieces and these two pieces look the same, that is a symmetrical lesion, so it's more percent that is a benign. In the malignant variant, the two parts of the tumor is not symmetric. If we cut it into pieces, it's not the same. B, it's a border. When the border edges of the mole are arranged or irregular, it's talk about the malignancy. C, color. When the color of the mole varies throughout, so we can see more darker area and the pale area in the one mole, and maybe area of the discoloration total or red color, it's feature of malignancy. Diameter. If the mole diameter is larger than the pencil razor, it may be malignant. Not in all cases, but maybe. And E, it's an evolution, so the tumor is grows. If it's grows, we talk about the malignant features. So now about the malignant melanoma or melanoblastoma. Malignant tumor of the melanin-producing tissue. This tumor occurs in both man and woman, and in the woman in 1 per 5 to 2 times often than the man. The average age of the onset is about 45 years old, but its recent years has become increasingly melanoma occurring in a very young adult, 15-25 years old. This tumor may develop on the skin, mucous membrane, eyes, meninges, adrenal medulla, perhaps the development of the melanoma from the nevi. Melanoma The most aggressive of all malignant tumors is faster grows through the several layers of the skin, destroying it, spread through the lymphatic and blood vessels of the other organs. Here you can see the features of evolution of the malignant melanoma. And the man has a photo of the mole in January 2008, and in March on the next year you can see that the mole increased in size in 2 or 3 times. So it's a typical features of the malignant melanoma. Types of malignant melanoma: superficial spreading, lentigo maligna, acrolentigenous, and nodular melanoma. Superficial spreading melanoma is by the far the most common type, accounting for about 70% of all cases. This is one of the most often seen in the young people. The same suggests this melanoma grows along the top layer of the skin for a fairly long time before penetrating more deeply. Lentigo maligna usually appears in the flat or mildly elevated, mottled toned brown or black-brown discoloration. This type of in situ melanoma is found most often on the elderly man and woman, arising on the chronically sun-exposed damaged skin of the face, ears, arms, and upper trunk. When this cancer becomes invasive, it's referred to as a lentigo malignant melanoma. Acrolentigenous melanoma usually appears as a black or brown discoloration under the nails or on the soles of the feet and or palm of the hand. This type of melanoma is sometimes found on the dark-skinned people and can often advance more quickly than superficial spreading melanoma and lentigo maligna. It is the most common melanoma of the African American and Asians, and the least common among the Caucasians. Nodular melanoma, usually invasive at the time it is first diagnosed. The malignancy is recognized when it becomes a bump. It is usually black, but occasionally is blue, gray, white, brown, tan, red, or skin tone. The most frequent locations are the trunk, legs, and arms, mainly of the elderly people, as well as the scalp in a man. This is the most aggressive of the melanomas and is found in 10 to 15% of cases. When we give the diagnosis of the melanoma, we may take in mind a lot of different factors. It's depth of invasion, level of invasion, its ulceration of the tumor, its quantity of mitosis, its level of the lymphocytic infiltration of the tumor, and the presence of necrosis and lymphangial invasion or perineural spreading of the tumor. All these factors connected with the tumor progression, with the prognosis of the tumor for the patient. So, breast lobe depth, what does it mean? It was used as a prognostic factors in melanoma, but now we use it for the other malignant tumor of the skin like basal cell carcinoma. It's a description how deeply tumor cells have invaded. In a stage 1, depth of invasion is less than 0.75 millimeter. Stage 2, 0.75 to 1.5 millimeter. At other, for what we needed, if the tumor is less than 1 millimeter, approximate 5-year survival is 95/100. But if the tumor is deeper than 4 millimeter, survival, 5-year survival, only 15%. Clark level. It's a related staging system using in conjunction with the breast lobe depth, which describe the level of anatomical invasion of the melanoma of the skin. It's more better variants of classification, as I think, because we have the same thickness of the skin in the different areas of our body, and we have the same thickness of the skin in different people. So what do we see? Level 1 Clark, it's when the melanoma confined to the epidermis, just epidermis, so it's a melanoma in situ, cancer in situ. Level 2, it's when it's invaded the papillary dermis. 3, invasion to the junction between the papillary and reticular dermis, and level 5, it's invasion into the reticular dermis. The more deep, more severe stage, it's invasion to the subcutaneous fat. High level have a worsening prognosis. Next, tumors of the childhood, peculiarities of it. First, the main tumor of the childhood are dysanthogenic tumors like teratoblastomas. Malignant tumors or in the childhood are less common than in adult. Non-epithelial tumors in children predominate over the epithelial. In children, there are immature tumors capable of maturation. It means that malignant tumor may transform to the benign, but it's a very rare situation. General classification of the tumor of childhood. First, teratomas and teratoblastomas, tumors which compose of more than one germ layer. Second, embryonal cambial tumors. And the third, it's a tumor of the adult type. First group, teratoid or dysanthogenic tumor. Teratoma is an encapsulated tumor with tissue or organ components resembling normal derivatives of the more than one germ layer. Gamartoma, excessively developed and normal component of the body, like blood vessels in the hemangioma, melanocytes in the melanocytic nevus. It's a gamartomas. Haristoma, the appearance of the tissue and characteristic for this organ, like dermoid ovariensis or struma ovary. Haristoma, also called heterotopia. It's abnormal location of the different tissues. Praganoma, tumor from the remnant embryonic structures. Teratoma of the ovary or dermoid cyst, very often present in the middle line of the body. It may be a coccygeal region, it may be mediastinum, but more often teratomas localize in the ovary and testes. In the ovary, we name it more often dermoid cyst. It looks like a cavity which covered by the squamous epithelium. In the wall of this sac presents different derivatives of the skin, maybe bones, maybe cartilage, maybe intestinal epithelium. Inside the cavity localize fat and hairs, sometimes teeth or underdeveloped extremities. Everything is possible. On the X-ray, you can see in this picture underdeveloped teeth in the teratoma. Here also you can see cross-section of the teratoma. It's a multi-located cavity with multiple cavities, and inside it present hair, fat, some underdeveloped tissues. Here also examples of the teratomas with a dermoid cyst with a fat tissue with the underdeveloped teeth, and extremities also present in the teratoma. Here also teratoma of the coccygeal area of the newborn. Sometimes in the teratomas may forms different malignant tumor. It may be a tumor of the epithelial region, so it will be carcinomas, or it may be a tumor of the mesenchymal region, and in this case it will be sarcomas. It's rare, but it's a very dangerous situation. Now we'll talk to gamartomas, about the gamartomas, vascular gamartomas named hemangiomas, and I show you these tumors. It's maybe capillary, cavernous, or mixed. It's maybe big and small. It's maybe single, multiple. It's may composed of the small slit-like spaces like capillaries or big cavities with blood inside. It may has no any clinical features or may have a lot of different symptoms. Muscular hamartomas include rhabdomyoma and rhabdomyoblastoma. Rhabdomyoma is a benign tumor of the embryonic muscle cells localized in the heart, muscles, or limbs. Diameter of the nodule is 10 to 15 cm. It's brown in color. Rhabdomyoblastoma, it's a malignant tumor of the embryonic source of the muscle tissue, localized in the pelvic organs like bladder, vagina, sex glands, and least it's a nasopharynx also. Gammatoblastoma of the internal organs. It's first, more frequent, it's a nephroblastoma. We also name it Wilms tumor. It's a malignant tumor of the kidney that's developed from the pluripotent renal metanephrogenic tissue. Long time had the expensive type of the growth, compressing renal tissue. Pinkish white on the cross section. Then it engrows into the surrounding tissue and metastasis. Consists of the solid field of the strands of the cells with oval or round nuclei, which are formed in the center of the tube-like renal tubules or glomeruli. Hepatoblastoma. It's a malignant liver tumor that developed from the pluripotent embryonic tissue. It invades the liver tissue in the form of numerous whitish yellow nodes. It grows fast, metastasizes quickly. It consists of the solid fields of embryonic liver cells, among which there are tubes and cysts resembling to the bile ducts. Tumor of the cambium of embryonic tissue. Medulloblastoma. It's a malignant tumor of the neuroectodermic embryonic stem cells, medulloblast. It consists of the oval or round cells that are orientated into the rosettes. Retinoblastoma. Malignant tumor of the undifferentiated embryonic cells of the retina. Tumor, gray-yellow, soft, composed of the round and oval cells, form rosettes, included necrosis and calcification. This tumor may be unilateral and bilateral. It leads to the protrusion of the eyes, affected small babies about 2 years old. Neuroblastoma. Malignant tumor from the stem cells of the sympathetic ganglia and adrenal medulla. The tumor is localized in the region of the adrenal gland, the sympathetic ganglia of the neck and the chest cavity, the retroperitoneal space. Tumor's nodule destroys the adrenal glands, and on the section we can see pinkish white color nodule with numerous necrosis and hemorrhage. Thank you for your attention.